Welcome to the
podcast.
To the Visceral Voice Podcast. Welcome to the Visceral Voice Podcast. I'm your host, Christine Schneider. Through this podcast, I aim to bring you the most current, up-to-date research on voice science, function, pain science, movement, and everything in between. I am on a quest to learn everything I can about the living, breathing body and its intricate connection to the voice. This podcast documents the continuation of my learning and my experience as a professional singer, a nutritional consultant, a movement specialist, and a manual therapist. Join us as we strive to provide current, knowledgeable, creative, and compassionate information to help you restore, regain, and create happiness and success on your vocal journey. Hello, everybody. Welcome back to the podcast. I am beyond thrilled today to be chatting with Dr. Eric Cobb. He is the creator of Z Health, and Dr. Eric Cobb is one of the world's leading experts in harnessing the power of the neurology of movement to create extraordinary change in the human body. Built on over 30 years of ongoing study, combined with real-world hands-on experience working with clients ranging from severely wounded veterans to Olympic gold medalists, Dr. Cobb has developed a global and holistic approach to health and performance based on the complex and ever-evolving interactions that occur between the brain and the body. Dr. Cobb is passionate about blending emerging research with established protocols to provide both practitioners and athletes with cutting-edge strategies aimed at eliminating pain and maximizing health and performance. Underlying everything he does is a deep-seated desire to help people realize the power they have to change, and then to help them find the tools and the skills to unlock their potential. Definitely speaks my language. With over 5,000 certified Z Health professionals in 110 countries, and I'm sure it's even beyond that by now, Dr. Cobb's work has played a pivotal role in bringing practical, neurologically based training into rehabilitation, training, and athletic systems around the world. Dr. Cobb, thank you so much for taking the time to have this conversation with me. I'm just so thrilled.
Thank you. My pleasure. Happy to be here.
Yay. So we're diving into the tongue, and we're really diving into the tongue today and talking all things tongue. And before we do, I would love to just hear about your journey into creating one of the most well-known established training centers and modalities that exists today. How did that happen for you?
Yeah, I get asked this question often on podcasts and interviews, and I wish that I had a super cool, positive story. But like most things, it evolved out of irritation, frustration, and poor results. So very long story short, I've been an athlete my whole life. I was a martial artist and a lot of different things. And then I got in. So when I was going through school, I thought, okay, obviously, I have a couple different directions. I knew I was going to do something medically related. And at that time, I grew up in a family that used alternative healthcare just as much as allopathic medicine. And so at that point, I thought, oh, well, I'm going to go be a movement guy. I want to be a movement doctor, because ultimately I tell people now, I realized that at that age, I really just wanted to be a better athlete and wanted to figure out, okay, what can I do to make myself a better athlete? So after my bachelor's, I did a pre-med human biology degree and decided to go to chiropractic college. So I did that, and it was a great educational experience. And I always tell people I appreciate everything I learned there. But what it really occurred to me during that time was that, and again, I mean, no offense to anyone, but I know that when I graduated, that I would have wanted my family to see less than 1 or 2% of the people I graduated with, because I'd spent 4 years with them. They were fine, but they weren't, how would I say it? They weren't super dedicated to continually evolving. And that's been my mindset my whole life. Now, with that said, I got out into practice and realized that although I had that very pretentious attitude, I was not really that much better. Right. So I started seeing real patients. I'd done my internship, and all my clinical hours. And so I had worked with a lot of people at that point, and I'd been coaching movement my whole life. So I thought, okay, I should be pretty good at this. As a manual therapist, coming from a martial arts background, I was pretty good with manipulating bodies and all the things that chiropractors would do. And thankfully, I went to a very medically oriented chiropractic program where we did tons of physical therapy, sports med, rehab. So it was very comprehensive from that perspective. And I got out into the real world. I started working with real people, and the results were fine, right? They were what I would call slightly better than typical, because I had set up my practice in such a way to say, look, I will see you 3 times. And if you are not making significant progress, either I'm doing something wrong, or we're on the wrong track. So I tried to be very, very conscientious of not doing what a lot of other people in my field did, which was just extending out, treatment forever for no truly valid reason that I could find in the literature. So over time, like I said, things progressed, but I would say that my success rates were interesting in that my practice divided up into professional athletes and chronic pain patients. That's pretty much all that I saw. And the pro athletes for me were interesting, and they were a lot easier to work with in many cases. But that got me wondering why. And then I also had some chronic pain patients that did wonderfully well, which is what filled up that side of the practice. But then I had some that obviously made almost no progress. So I had this really cool referral network, which was great. But then I had a patient interaction that really changed my perspective on things tremendously. I always tell this story, and I always tell people this: Z-Health really was initiated through being, I guess, instructed of my own ignorance of things. And this is what happened. I had a very nice older lady to me at that time. She was in her early 60s. Now it doesn't seem too far away. And I was working with her. She had chronic headache and neck pain. So she'd come in. I'd done my initial evaluation. I was treating her. I treated her twice, and she was definitely in that chronic pain bucket where there were mild improvements. I could feel changes, in the soft tissues. There was a little bit more mobility in the joints. She was moving a little bit better, but she wasn't really getting a lot of pain relief at that point. I'd seen her twice. So I scheduled her for the following week, and didn't really think anything about it. And then I was in my waiting room. I looked out. I saw her coming into the office from the parking lot, and she was moving a ton better. And so I got excited. I was like, awesome. And so I went in, and when I went in to see her in the treatment room, I said, "Hey, you look like you're doing great." And I started my little spiel, and she's like, "Yeah, Mike," she said, "I'm feeling amazing. My neck feels fantastic. I can move it so much better. I haven't had a headache in a couple of days." And I immediately launched into my practice speech of, hey, whenever we're doing work on the body, sometimes it takes time, right? I started launching into that whole explanation that we seem to all have patterned so well whenever we work with people in this field. And that was about a minute into it. And she was like, let me just interrupt you. She said, "I don't think that's what it was." And I went, "What do you mean?" And she went on to explain. She said, "Well, earlier this week," she said, "I went to see the optometrist. I haven't been in about 5 years. And I got there, and he started looking at my eyes, and my prescription was it was an absolute disaster." Said, so he gave me a new prescription, and they made them, she went to like the 1-hour optometry clinic. She said, "I got new glasses on Wednesday, and I was seeing her on a Friday." She's like, and I put them on. She's like, "An hour later, my neck quit hurting, and I haven't not had a headache since." And so I'm in the treatment room and I'm looking at her and I'm like, okay, there's two ways I can play this, right? Like either act like this is a normal thing or go, wow, that's really interesting. So I went with the, wow, that's really interesting. And then I absolutely obsessed for the next 30 years. Because it was a really direct indictment, if I can say that, of my education at that point, which I think it was probably the most striking, one of the most striking experiences of my life to say I invested at that point over $500,000 into being a neuromusculoskeletal expert. And I could look at your eyes and I could go, oh, wow, that's, you've got nystagmus from this or whatever. But I had really zero information or understanding of the functional relevance of eye movement, eye function to pain syndromes. And then from there, everything has just exploded into, it really caused me to transition into thinking much more from the neck up as opposed to the neck down. Because in the real world, most pain and movement approaches ignore everything from the neck up. So when you really dive into neurology, one of my favorite quotes is, everything we are is brain derived. Everything you've ever felt, seen, heard, everything you are, everything you will be, it comes from the brain. So to me at this point, after 30 years of yelling this, it seems evident that every practitioner in every field that works with another human being should have at least a passing expertise in how the brain and body interact. And so that's really kind of what built Z Health as a system. And, there's a lot of other practical experiences in this. I was in the midst of a lot of life adventures. I was a military contractor overseas and had some injuries. I got blown up and had lots of friends that had lots of injuries. And head traumas. And so that also got me very, very interested in neurologic rehabilitation. So like I said, I've tried to blend all this into a system that takes really complex ideas and says, but this is what it means today, right? How do you take that information and do something with it? So that's the basic journey so far.
Wow.
We'll see where it goes from here.
Yeah. Well, thank you for all of the work that you're doing and the many practitioners that you have trained, because it is the ripple effect within the world. And we are so grateful and lucky to have had your journey and your expertise in really looking at the brain as the foundation of everything. So thank you for all of that. So we're going to, I mean, we could talk obviously very much, so much about the brain. And of course, this is a podcast for the voice. So we are practitioners that very much have to look top down, because it's our airway. So what's happening above and what's happening below matters with what's happening right in the center. So
absolutely.
I am grateful, because it is very hard to find practitioners and modalities that, obviously I'm trained in cranial sacral therapy and everything, but, and visceral manipulation and those kind of things, but to be able to have additional resources of neurology and how it actually impacts movement and movement training and biomechanics. It's extraordinary. So you mentioned the eyes, which of course the eyes are so important with our entire experience of safety and movement. And so again, we could spend an entire episode talking about the eyes. But today we're talking about the tongue. So we're coming a little bit lower. So to talk about the tongue. So first, let's start with kind of bringing in that whole body and the tongue and the body system. So how does the tongue connect to and influence other parts of the bodies, other body systems, and our overall body function and our coordination?
Good. We'll start with something simple. So probably the easiest way for me to start explaining any of this is I always tell people everything we do is applied neuroanatomy, right? So at the most basic level, we have to begin with the tongue itself and we go, okay, how does it work neurologically? So, based on what you were telling me before, I'm going to assume most of our listeners understand that we have sensory motor systems. Since sensory systems are primarily to provide information to the brain about what's happening in that localized environment. And then we have the motor component where the brain is now enacting something to change our world, right? So we tell people the nervous system does three things. It takes in information or inputs. It integrates, assesses, and decides on what that information means. And then it creates some kind of motor output as a result. Now, that motor output could be something like thinking about doing something, or it could be enacting a physical movement, physical skill, etc. So that's the basic functioning. So we start thinking about the tongue. We have to look at its sensory supply first, because the sensation, let's see, how is a better way to explain this? Whenever we are looking at brain function, we are interested not only in the localized area where information is going to come into the brain, but we're also looking at everything around it. And also that it's connected in networks to it. So in other words, if I touch a spot on my hand, I know that that's going to, if I touch my left hand, that's going to create activity in the right sensory cortex, my parietal lobe on the right side. But people have seen pictures of what's called the homunculus before. The homunculus is the little man in the brain. And there's not just one, there are hundreds spread all over. And we're learning more and more about them right now. But we can kind of go back to Penfield's diagram, but there's, if people are familiar with that, that's the really weird looking dude, homuncular representation. That's been updated recently, I think last year. Because now we're understanding that more and more that the homunculus also has a functional bias toward it, where there are what are called effector regions that are spread throughout the homunculus that allow for more coordination of inputs. That's a quite interesting component. But again, the idea here is we can kind of know where in the brain that touch is being processed. That touch, because that's going to involve an increase in electrical signaling in that area, a release of neurotransmitters in that area, and an increase in blood flow in that area, particularly if I'm using like a vibration tool or something. All of that is going to create an overflow to surrounding neurons, which may cause activation or inhibition depending on what we're doing. So when we talk about the tongue, we go, okay, well, first and foremost, how is it getting information to the brain and where is that going? So when you look at the sensory for the tongue, you have a bunch of different cranial nerves that are involved in sensation. So I'm assuming people know your cranial nerves, but one of the big ones called cranial nerve 5, trigeminal nerve. So for the tongue, we have 5, we have 7, we have 9, and 10, right? So we have 12 cranial nerves, 12 sets of cranial nerves. 4 of them are going to take in sensory information from the tongue. And I always tell people you can understand how important something is neurologically, often by looking at how many redundancies are involved. Mm-hmm. Redundancies means how many different ways does the brain have to receive information from that area. So the tongue is incredibly important from this perspective, because it's getting it is being allowed the ability to communicate with the brain through 4 different cranial nerves. So we know that we have those 4 involved. We then also can look at, okay, well, where are those nuclei? And what that then tells us, that tells us where in the brainstem the tongue sensation is going to be processed. So whenever we look at this, again, we have 5 and 7. Those are going to be in the pons. All right. So if you don't know your brainstem, on the top, you have the midbrain or mesencephalon. In the middle, you have the pons, and on the bottom, you have the medulla, right? So that's kind of our stack. And these do different things. This is really cool. I love brainstem neuroanatomy and neurology because it is basically about 90% of what makes us move well or poorly. Mm-hmm. So we have 5 and 7 in the pons, and then we have 9 and 10 that are going to be in the medulla. So whenever you look at that, just from that perspective, that means that the just sensation from the tongue has a tremendous capacity to alter blood flow, neurotransmitter release, and neuronal signaling in 2 of the most important areas of the body that cover everything that we do, from locomotion to respiratory control to our breathing patterns immune function, pain, either pain inhibition or pain propagation. All of those signals and more are going to be passing through the brainstem. So whenever we start trying to identify, are there certain parts of the body that could be looked at as, I guess, key centers for being able to influence areas of the brain that are going to have influences throughout the rest of the body, the tongue sits as one of the most important areas. So is it involved in coordination? Yes. Is it involved in pain? Yes. Is it involved in endocrine function? Yes. Is it involved in respiratory control? Absolutely. The problem is that this is a very new perspective on the tongue. So if you're going to try and dig into the research, I will be the first one to tell you there's not a lot right now. And a lot of the research that is available on what we're going to, some of the other stuff we're talking about today, it's limited, which is fine. That's the research world. You have to get people interested in it first, and then they have to be funded second. And then there has to be something actionable out of it eventually. And then that has to be disseminated out. So for me, this is a really cool opportunity to have a conversation around it. Is that a sufficiently long and complex answer, or does that make sense?
No, that was so great. Yes, definitely makes sense. To the listeners, Dr. Cobb just mentioned 5, 7, 9, and 10. So
and then we have
we're talking about
motor, by the way.
And 12 for motor. So we have the sensory of trigeminal, facial, the glossopharyngeal, and the vagus, and then we have the motor of the hypoglossal nerves.
Right. And there's a little bit of vagus as well, an accessory nerve as well, in the palatoglossus muscle. So we could actually extend this out to maybe saying, okay, we have 4, 5, 6, maybe even 7 cranial nerve combinations that we could, or interactions with the tongue. So yeah, it's a pretty big deal.
Yeah, a really big deal. And I want to skip really quick to stimulation, because that's an area right now that I've been hearing more and more about, of using tongue stimulation for things like sleep apnea, using tongue stimulation for MS, for Parkinson's, and because of the ability to go directly into several different aspects of the brain. And then in something like traumatic brain injury or Parkinson's, the motor control component of the relationship with the tongue and motor control. So with our tongue stimulation, can you just chat a little bit about what I'm even talking about with tongue stimulation and the benefits with individual conditions like Parkinson's, MS, etc.?
Sure. Okay. So probably the easiest way to, I guess, help people understand this, let's talk about the PONS device first. If people are unfamiliar with this, I highly recommend you go read the amazing book, How the Brain Changes Itself by Norman Doidge. The first chapter or second chapter, I believe it's the first chapter, discusses a training system. It's called the PONS unit. And it's funny because I, probably back in 1997 or earlier, I actually had a conversation with one of the developers of this unit all the way back then, right? So it's taken a long time for them to really get this to market. But the basic concept is built on neuroplasticity, right? And the idea that the brain can be reshaped consciously, intentionally, if we can figure out how to talk to it. So at the time, I was actually meeting with, or having conversations with one of the inventors of the PONS unit. I was focused on athletics and sports performance and working with the military and other things. And so he had emailed me and we had a conversation. He's like, yeah, I want to help blind people see with their tongue, basically, was the whole concept. And I went, wow, okay. There are people way smarter than me in the world. That was my first response. And just an amazing perspective. And just, I love people that have these types of brains that I think I tend to be more on the practical day-to-day, but there are people out there trying to solve very, very big problems. And this was one of their concepts. And so we got into long discussions about neuroplasticity and how do we access as many areas of the brain in an unusual way as possible, because one of the things we have to recognize, the brain, there's a whole theory out there called the lazy brain theory, which is basically that your brain, once it has achieved a comfortable level of expertise in anything, it says, I'm going to stop paying attention. I'm going to turn this into some kind of habitual response, because you know what? It's so much work to try to change, right? So this lazy brain, or, people talk about it's all about calorie conservation because we come from a famine-based, evolutionary background. And I think there's probably a lot of truth to all of that, but based on practical experience. So the PONS unit was developed, and they were looking first, when they were trying to figure out, okay, how could we help the occipital cortex of a blind individual relearn how to see utilizing alternative sensory modalities. That's the idea. And they began using sensory stimulation of the back. So they built a chair, and they used basically, you can almost think of it almost like TENS unit, but very discrete electrodes, and they would use these different patterns, and they then began linking those patterns to shapes and other representations. And just through a lot of trial and error, they began to understand that blind people were actually being able to see different things using the skin of their back. But that's a very impractical solution, because you can't walk around with a chair strapped to you all the time. So then they thought, okay, miniaturization, and how, again, can we access as much of the brain as possible? So they've gone on to develop the PONS unit, which is now a small electro tactile device that sits in the mouth and makes contact with the tongue. I believe there are like 146 or something electrodes, and basically, when you combine the PONS stimulation, it's electrical stimulation of the tongue, with other training modalities, you can drive plasticity in specific directions. So for PD and MS, it's being used a lot for gait retraining right now, because some of the earliest indications were that we would be able to change vestibular function. So vestibular system, for people that are unfamiliar, that is your inner ear, your onboard balance system that allows you to understand your relationship to gravity. And even small dysregulations in vestibular function can have dramatic, just truly dramatic effects on movement and pain, etc. So they did some trial studies with the PONS unit, and the reason this is important, and the reason we talked about the anatomy previously, is that the vestibulocochlear nerve is cranial nerve 8. And so whenever we start to look at where that's at, that is in the PONS. All right. So remember, we also from the tongue had 5 and 7. So we now know that if we stimulate sensory information on the tongue, we're hitting 5, we're hitting 7, we're hitting 9s. So we're basically surrounding the vestibulocochlear nuclei with stimulation. So when you couple that, and I like to talk about this from a motor learning perspective as priming the brain to learn. When we prime the brain and activate that area of concern, and then couple that with additional training, whether that's movement training, gait training, visual training, we can create an environment in which neuroplasticity can occur much more readily and much more competently. And so there are pretty decent studies right now on gait changes in Parkinson's and in MS using the PONS device. So that's kind of the general basic idea of stimulation. Now, what form the stimulation can take? Well, right now, the PONS device is kind of leading the charge, I think, on the plasticity side. However, there is ample evidence from the rest of the body that we can use vibration. We can use any sensory stimulus on an area and drive these activations in the brainstem. And if we couple that or stack that with other movement training or rehabilitative approaches or whatever, we often can see motor learning occur much more quickly, and we can actually help people learn to do things they've never done before through this idea of what's called sensory substitution. So I think, does that kind of cover the question?
Oh my gosh, yeah, that was unbelievable. I found the PONS device several years ago. I was teaching a class on the tongue, and I was, of course, doing all my little research behind the scenes, and I found the PONS, and I was blown away.
Yeah, when you actually see it, if people are interested, there are a few great YouTube videos. And in fact, they did a training program. I don't remember the gentleman's name. He's a blind climber. He climbed Everest. They have a fantastic YouTube video of him going through the training process with the pawns, and then him being able to recognize his child and being able to read letters. And he is blind, but he is seeing with his tongue. It is, if you want to have hope about changing things, it is truly it's one of the most awe-inspiring things I've ever seen. And like I said, there's a part of me that really wishes that my brain was shaped in that direction, because I find people that are so dedicated to finding a way to like deal with these very big problems. I find them incredibly amazing, and the athletes that are willing to put themselves through the experimental processes. It's all fantastic. So anyway, yeah, stimulating the tongue, very big deal and very powerful. We use it a lot. We've been I would say probably for the last 10 or 12 years, used a lot of vibratory stimulus for the tongue, a lot of movement exercises, and what you'll hear in a lot of our advanced courses is we use that as a priming tool, or what we call a stacking tool, to help promote faster and more complete rehabilitation or motor learning.
Mm-hmm. And you use the Z-Vibe too, right? That's in a lot of speech therapy too. Yeah. Speech.
A lot of the speech therapy community's done fantastic work, obviously, in this area. And in fact, OTs and I think a lot of speech therapists, when I work with them in my courses, they're often more familiar with a lot of the basic neural functions than any other professionals, which I love seeing. So the main thing to remember is this, in terms of stimulation, tongue stimulation. What we have to be able to avoid with any kind of stimulatory training to drive plasticity is basically habituation. Meaning I can't remember the term right now, but it's like basically they'll call it local deafferentation, which means that it's transient. But if I put a massager on you, right, it's vibrating at a certain frequency and a certain amplitude, at some point I'm going to maximize the resources locally, and then the brain's going to be like, okay, I have no more interest in this, right? In other words, we're going to deaden the afferent information coming in. So the key typically with stimulation is figuring out your parameters. How often can I do it? How long can I do it? Can I change the frequency of stimulation? Because often what we will see is that if you don't change some parameter every few minutes, you will begin to lose the attentional resources. The brain will be sent elsewhere, and then you won't get the hoped plasticity effects. So you have to change it up. So one of the things that I encourage people to do if they're using the Z-Vibe, right, is figure out, are there ways that you can manipulate the intensity of the stimulation? Sometimes just changing areas regularly is enough, but sometimes clamping down on it to alter the amplitude will help. I have done very weird things like wrap it in cotton and other things. In other words, just because for most of us right now, from a practical perspective, Z-Vibes or other vibratory tools are about the only really easily accessible thing we have. There is a company that makes, for home use, like TENS microcurrent stimulation units that now they are making a tongue unit, which I think is pretty cool. I've had it for about a year now. I've experimented with it. I think it works pretty well, but again, that's much more of an investment than Z-Vibe and cotton. And so that's one of the things you had also asked about in the research field is, what are we missing? These are the questions that need to be answered. We don't yet know, honestly. Is there a significant difference between electrical tongue stimulation and vibratory stimulation? Is there, there's so many different things that we can do that we don't have answers to yet. So right now, you're definitely on that cutting edge of, okay, we're just going to have to try some things ethically and see what the results are.
Yeah. Oh my gosh. So I'm going to move into kind of lymphatic because
Okay.
we're going to go all over the place because the tongue is a lymphatic organ. So the
Yes.
brain has a lymphatic system and it helps to get waste out, definitely when we're sleeping, but all throughout. So we have these glial cells and we have this lymphatic system, and then it helps send it out to the lymph nodes of our body. And certainly we have a lot of lymph nodes in the neck.
Mhm.
So how does the tongue help to, and I know, and we can venture right into the spot and finding the spot of the tongue, because I think that's part of
Right.
being able to help with the lymphatic system. But so how does the tongue help with the lymphatic system? What is the spot that you have on a YouTube channel? I know that you talk a lot about the positioning of the tongue and where the tongue should be
Yeah.
resting in its resting state. So if you
Right.
don't mind kind of going into
Okay.
that grand topic.
Here we go. So, a lot of different directions here. So let's start off with we'll just start off with basic lymphatics. So yes, you're correct. The tongue is a part of our immune system, right? It's a first detection area. So the tongue has immune functions, right? There are macrophages built into it. And so there's also some really interesting initial research happening right now looking at the tongue having or driving immune responses based off taste as well. We taste something, oh, that's sour milk. Oh, we better start preparing for whatever bacteria. So it's a really interesting combination between the tongue and kind of the lingual ring as food's passing into the digestive tract. We have a lot of different bacteria, a lot of parasites. So it, number one, has obviously a very, very powerful initial immune impact on us. So having said that, we have to then look at the lymphatic system. Where does the tongue drain? So if we have, we bite our tongue, right? And so now it's swollen and we're dealing with all that. It's going to drain into our deep cervical lymph nodes. And if you're familiar with the lymphatic system at all, we're basically going to put everything back into circulation eventually, which means we have to have some big ducts that collect the lymph. And then after, hopefully it's been cleaned, and then it's going to go back into our circulatory system, which I've found really interesting teaching for years because a lot of people don't realize that. They think like the lymphatic system is a self-contained deal. And the circulatory, they're not. They are connected. So we're always looking at collection points. So the deep cervical nodes are a big deal because those are going to then lead into the thoracic duct, and the thoracic duct is going to dump it back into circulation. So the lymphatic system is really interesting in that we still really don't know that much about it. It's not super well studied. It's obviously studied from a pathologic perspective when we look at cancers and we look at metastatic processes. So we kind of know what's going on there. But in terms of this basic function of how do we improve it? What do we do? Does breathing really impact it? Does movement really impact it? And even those basic questions are actually still not fully decided on, which is bizarre. But that tells you how little we've actually looked into improving it. So my bias, I'll tell you right now, is that so gravity helps. Sometimes gravity is also a problem sometimes for the lymphatic system. So we have to understand that. We have to understand kind of local contractility, which is neurally driven. So if I have areas that swell, I probably also have poor motor responses coming to that area and from that area, or afferents from that area. So we spend a lot of time looking at things like that, number one. So whenever we're considering the impact of the tongue in general on lymph flow, if we say, okay, is tongue movement going to influence lymphatic drainage? The general answer I would give is probably has a tremendous impact, but only when you use it non-habitually. I can say it that way. So, think of it this way. If I have problems with lymphatic drainage from, let's say, my jaw, my tongue, my throat, I have chronic tonsillar issues, I have brain fog because I have poor lymphatic drainage, etc. I'm going to be really interested in looking at your habitual tongue position, your habitual tongue usage, and then trying to do something different with it. In the osteopathic professions, they spend a lot of time trying to detail out the fascial relationships of the base of the tongue with the diaphragm, the respiratory diaphragm, the pelvic diaphragm. And so when you actually kind of dig through the fascial connections as well, motions of the tongue that really drive activity toward the base, you will dramatically feel, depending on positional flexibility, you'll feel that dramatically in areas that will impact on movement around the deep cervical nodes. So I think tongue mobility, tongue strength, and tongue range of motion all probably do play a role and can probably play a more significant role in eventually what's going to occur within the brain. In terms of a direct connection between the lymphatic system and the tongue, I am not familiar with a single research paper on this. I've looked for it. Right now, there's nothing detailed about that. Now, having said that, let's be very clear, that does not mean it does not exist. It just means that no one's found it yet, because we didn't even know the brain had lymphatics until, I think, 2017, which is patently absurd, but we didn't even know, right? I actually remember when the paper came out, what a big deal it was, and these neuroscientists are like, we're going to have to rewrite the textbooks. Yeah, that would be important.
It was so exciting in the cranial sacral community, because Tad Wanvier does a lot of that work with glial cells, and it was very exciting of like, yes, the brain has
it has them. And now what's cool is you've actually seen a huge shift in conversations around dementia, around Alzheimer's, Lewy body neuropathologies. So now things that we really had no idea what was causing it, now we can go, well, maybe it's a drainage problem. Like that makes sense. And there's actually, in MS and other things, we're starting to see maybe some more evidence of that. So obviously, still a lot to discover. Right now, most researchers, I think, would say there's kind of an indirect connection between tongue and lymphatic drainage. So let's now connect this to sleep and sleep apnea. So sleep apnea, whenever we look into that, it's quite evident that the tongue plays a big role in this. Okay, now it's not the only driver, but it is a big driver. So if we think about this really simply, a lot of people with apnea, if we lay them on their back, what should happen is the hypoglossal nerve, which is our primary motor nerve, during sleep should be active and should be driving the tongue anteriorly in order to maintain a patterned airway. So what is showing up in sleep apnea studies at this point is that there is a significantly decreased hypoglossal drive to the tongue, which is now considered kind of one of the primary causes of apnea. When we then look at that as okay, how then is that going to impact on lymphatic drainage? Well, while sleep is the area of research where people are like, okay, the brain only cleans itself during sleep. No, that is not true. That was all or nothing in the body is almost never true. The lymphatic system is always active, but we do know that sleep is a primary time for the healing process to occur. And so sleep apnea, obviously by chronically interrupting the sleeping cycles, seems to be deeply linked into dementia, to Alzheimer's. So things that are going to cause collection or potentiate, I would just call it, poor drainage of the brain. So again, these are kind of all indirect connections right now, but I think it's pretty easy logically to say, okay, if I have poor hypoglossal function, which is allowing apnea to occur, the interference with sleep and breathing, both of which are going to be deeply linked into lymphatic drainage, those are going to be interrupted. So now we can see this kind of causal connection between this and these subsequent pathologies. So what's very interesting. This is a paper from 2023 that I have a lot of interest in breathing, obviously, because breathing is one of our, big deals for the brain and for basically staying alive, last I checked. But particularly in apnea, what they're finding is, I know people are probably, if they've listened to anything I've talked about, we talk a lot about CO2-based breathing methods, where we want to build up carbon dioxide because it is a transport molecule. It's not oxygen good, carbon dioxide bad. We need both. And most people, if they're going to have a breathing respiratory issue, they hyperventilate, so they're over-oxygenated, etc. So we spend a lot of time trying to get people to relax, learn how to do exhalation-based breathing, try to increase CO2 levels intentionally, because there's a lot of good things that come from that. I think fewer people are familiar then with carbon monoxide, other than to go, okay, isn't that how people die, like breathing carbon monoxide? Yes, if you breathe too much of it, but it is a key signaling molecule as well, particularly in the brainstem. So carbon monoxide is one of the key chemicals that causes the hypoglossal nerve to be active during sleep. So now this is some of the testing that's going on, is they're trying to identify, there's like hydrogen sulfide as well. So it's a catalyst that will create the carbon monoxide. The carbon monoxide is going to be dramatic or deeply involved in the regulatory nature of the hypoglossal activation during sleep to keep the tongue correctly positioned. So we're now starting to see maybe there's some therapeutic ideas there. The practical implication of this is that our circadian rhythms are also driven by carbon monoxide. So if you have people that have depression-like symptoms, SAD, seasonal affective disorders, or sleep apnea, you may want to actually consider doing a lot of light therapy with them.
Wow, you just blew my mind with that. I knew all of the CO2 tolerance training, but I did not know that at all about carbon monoxide.
This is like I said, I think this paper on particularly related to apnea, I think it's from like 9 months ago.
Wow.
So don't feel uncomfortable. I did a presentation, I did a webinar, I don't know, last month, and one of the ideas in it was just talking about the research gap. When I was in school, pre-internet, we talked about a research gap of lab to practical application in the field was about 15 years. With the internet became available and academics and etc., I was like, oh, thank God, this is going to get better. It's worse. 17 years right now is the estimation from current lab research filtering down to field practitioners to generalized usage. So I guess, I love talking about neurology and all these things, but one of my big encouragements is if you're a movement professional and you think that what you're currently seeing from other people, unless they are able to go, here's a 23 study, here's a 24 study, make sure you're doing your own due diligence, because things change. That's probably, I tell people, that's 90% of my job right now, is just trying to stay current and trying to interpret what's current into, here's how this fits into what we already know. Here's what's new. So yeah, I find this a really big deal. And I actually love the fact that you can find studies looking at bright light therapy for sleep apnea. You go, okay, well, I can do bright light therapy for seasonal affective disorder, for depression, and also apnea. Okay, what's the neurochemical basis of that? And it looks like right now this carbon monoxide link is a pretty big deal. Yeah.
I think that's why so many of us practitioners get so frustrated for all of the next generations who are coming through the schools, learning the same thing. And I still hear to this day, just so you know, my background is in massage therapy, and it's just so you know, everything you learn in school, you're going to have to relearn because it's all wrong. And I'm like, why? Then update the material. Why do I have to spend all of this? I mean, for massage therapy, it's not as big of a deal. Certainly in New York, because we have to have the most training of anywhere else in the country. Right. So it's a little bit more of a financial investment. But when you're looking at PT schools and you're looking at chiropractor schools and osteopathy and med school, when you're looking at spending a substantial amount of your life in school, I'm getting on a tiny soapbox now, but when you're looking at spending that amount of financial resources and knowing that you're going to be in financial debt, and then finding out that everything, not everything, but much of what you're learning, you're going to have to relearn. It's harder to relearn than to just learn it right the first time. So,
well, I had a number of years ago, I had been approached by a couple of different universities to include our curriculum in their either chiropractic curriculum. I had a couple that were interested, hey, can we create a master's program in this? And so in the US, I had conversations, I think, with 3 different universities about this. And in each case, one of the big conversations that came up was, well, I would tell them, I'm like, I update our courses every 6 months. And they went, yeah, you can't do that. And I went, what are you talking about? They're like, yeah, we don't know. Once it's set, it's set. And I'm like, well, how often do you review? And they're like, well, and this was, again, however long ago I was having this conversation. They said, I think at that point, Stanford was the leading university in the US, and their intent or their demand at that point was every 7 years, the curriculum had to be updated. And I was like, yeah, that will not, I just can't, I can't wrap my head around that. That doesn't make any sense.
That's so long for all of the information we're learning about the human body.
So, and like, I understand it. You have to standardize. You've got to build the exams, etc. I have this conversation all the time. My son is actually in his first year of residency as an internist. And he's been doing research since he got into med school. So we have this conversation all the time about how research is done. Is it meaningful? Is this just for people to get papers out there? You know, what is really significantly changing? Is there anything significantly changing medical practice? So he's involved in one right now that's really cool, that if the results pan out, it's going to save people, you know, a procedure that was $2,500 is going to be $50 and reliable, which is really cool. But we then had a conversation about, but if you can prove that, how long is it going to take for that to get out into regular practice? And the little debate we were having, he said, well, it could be a long time based off the research gap. And I'm like, yes, but it's financially driven. So if an insurance company can say, hey, we're now going to be able to do that versus that, I bet you it's going to go out a lot faster. So, you know, unfortunately, research is done by real human beings that have real jobs and real responsibilities outside their work. And so I think the research field is so vital, but it's also deified in some cases and vilified in other cases. And it's just folks, right? It's just the guy next door or the person next door. They just happen to study the brain, or they happen to study this. So I try to tell people, you've got to stay current. You also have to stay practical. You also have to stay skeptical of everything. Like I tell people, I'm skeptical of everything I read, and I'm including myself, right? Not because any of these people have poor intentions. It's just that the human body is marvelously complex. And what's more interesting is that it is far more individualized than we would ever want to expect or appreciate. Because as a researcher, it'd be awesome if everyone was the same, because then nothing screws up my stats, right? But if you've been, you know, blown out of a tank, you're not going to respond the same way. If you've had a traumatic childhood event, you're not going to respond the same way. And so I love working with people like you and people who have a deeper appreciation, understanding of the need for individualization, that we're not robots. We are not machines. We have traumas. We have victories. We bring all of that into every training session. And so elite coaches don't do really cool stuff. They just do very smart stuff. And that smart stuff is typically governed by knowing who you're working with and shaping the training in such a way that it takes advantage of what they're great at and helps them figure out how to shore up the weaknesses, right? So sorry, that's a big soapbox thing for me. So anyway.
No, I so appreciate that. And it can lead us right into, we were just talking about the trauma. So it can lead us into the emotion and mental health. So are there connections between the tongue posturing and emotional or mental well-being?
So again, we're in the research topic. The answer seems to be yes. in that we do know that we can see different tongue postures that accompany different emotional states. An easier way to explain this would be to say, hey, have you ever watched a kid or an adult doing something very complex with their hands and they're sticking their tongue out? Right? I always tell people the most famous, what I call tongue engram in sports history, is Michael Jordan, right? Every time he was doing something hard, had that tongue out. That's a very common thing.
Yeah, my brother does it when he plays the drums.
Yep.
Yeah.
So you'll see that, and there's some cool papers out explaining there's this integration between the hands and the tongue and why we might see that. But what we do know, for instance, is like if people are experiencing fear, if they are fear or anxiety states, they will typically drop the tongue to the bottom of the mouth. Now, that is not great for a lot of different reasons. They will sometimes thrust it anteriorly, but place it in the bottom of the mouth. The idea here is I'm trying to maximally open my airway just in case something bad happens and I either need to scream or run.
So right? It's not that the tongue is swelling. It's that they're bringing it down to the bottom of their mouth and thrusting it forward. Right.
And they're trying to actually make sure that, hey, if something bad happens, like I said, I can get out of here. So there's a paper, I think, from last year, and if you want, I can try and find it for you, that looks at some other kind of tongue posture, emotional correlation. So we are seeing it. A lot of the studies have been done in primates, right? Non-human primates, but we are seeing a few that are showing up in humans as well. So is there a connection? Yeah, most definitely. And I don't think they're probably that hard to figure out. The interesting aspect of it from a voice coach perspective, or let's say I'm an athletic coach, is what does that then mean for vocal performance? What does that mean for athletic performance when my performer is in a high anxiety state? How is that going to impact on their breathing? Is that something I can make them aware of? Is that something that we can do specific training sessions around so that we can either learn how to manage that anxiety state better, or we can go, hey, when you are getting afraid, you got a little stage fright, you got a little bit of performance anxiety, just know that it's going to impact your tongue position this way, which may impact your breathing this way. So the issue would be, obviously, if I get into this kind of fear-related tongue posture, I open the airway, I will become more tempted to mouth breathe, which will then begin this whole cascade of dysregulation. So I may have decreased endurance, decreased motor coordination, decreased cognitive capacity.
And dry mouth.
Absolutely. Massively dry mouth. Yeah. So, I think it's a really cool, interesting correlation that we're seeing. And right now, I think for me, that's the one that I have been most focused on in terms of if I'm going to work with someone in this kind of subtle level. It's more about the managing anxiety states because of the subsequent downstream effects of the tongue position.
Oh my gosh. I mean, that's, if nothing else blew everyone's mind, that absolutely would, especially with all the voice teachers and everything, because we are performing is not a natural thing to do. So at some point, I was
sweating getting on here to talk to you. So
yeah.
I tell people 30 years I've been speaking in public and I still get incredibly nervous every time. So.
Yeah. And our performers do too. And, that's a response of the body. And if we have these natural responses that are happening in the body, but they make us more anxious. If the artist just knew that, oh, this is what happens, this is what's happening, this is a natural response of the body.
Right.
If you can actually just continue to have the spot. Speaking of the spot.
Yes.
Can you bring us into the spot? Yeah.
Yeah. This one, I won't spend a ton of time on because, this is pretty easy to Google at this point and look at.
Yeah. You have a great YouTube video and a blog. So check out the blog, check out the YouTube video too.
So this has been under discussion for a long time. Like, is there a proper resting position of the tongue? If you look into some of the orthodontic communities that really look at craniofacial development, one of the things that they're basically always trying to get across is that as we are developing, we need the tongue to provide some kind of dental or cranial vault support. So in general, the way that the spot is taught is that the tip of the tongue is going to be just behind the upper incisors, with the lips either closed or gently closed, and the teeth either just touching or slightly not touching. I'm like, really, if it's that level of detail, no one has the amount of concentration necessary to deal with this. We're probably not that fragile. All right. But the main thing is getting that tip of tongue contact up into the roof of the mouth, and then learning as well how to bring the rest of the tongue up into the palate. So the way that we typically teach this is a really dumb exercise called the cheesy grin. And so it's done like this. You take the tongue, you put it just behind the top incisors. You hold that, you get into a really big smile, as big as you can, and then you swallow. And that swallow, you will feel, hopefully, the posterior aspect of the tongue elevating along the roof of the mouth. Now, that is kind of in the, like I said, the craniofacial community, that is typically taught as the ideal resting position, with the posterior tongue also elevating, because as we move and breathe and swallow, that will cause some minor anterior, posterior, and inferior, superior drive of the tongue to help shape the vault. There are other people in the research field that don't believe that the posterior tongue positioning is as vital as the anterior positioning. I don't think we have enough evidence either way. It is far easier to get people to focus just on the tip of the tongue in terms of habit formation. If I can get them to do that, then I might progress into more of the cheesy grin work over time, so that they can start working on developing more complex motor control of the tongue. And again, this is a lot of what we do when we look at brain activation and brain function. We eventually have to move people away from habitual everything in order to drive plasticity. So if nothing else, I love teaching these spot drills as not only a resting position of the tongue that will enforce nasal breathing, which is one of the big keys, but will also over time increase your motor control of the tongue itself, which we can shape it, we can expand it, we can contract it, we can lengthen, we can shorten the tongue. All of those are very, very cool things to be able to do with it for a variety of reasons, including singing.
Yeah, of course. Yeah. I have a torus palatinus, a big one, but I don't think that it impacts. I'm a nasal breather. I can get my tongue there. It's pretty happy to, I think I get there easier because
exactly. Like, oh, I can find that.
I feel that right away. Yeah. Great. So before we finish up, is there anything that you would want to say to the vocal community about anything else regarding the tongue that you would say that you would want them to know?
Yeah, I think we've actually covered on a lot of the things that I find important and interesting. There's so much more out there. I think number one is, even if your primary focus is on the vocal coaching art, don't be afraid of the research side. I always tell people that neurology seems really complex, but just like any other skill set, there's foundations, and once you have foundations, everything else just kind of starts to layer on top of it. The problem is it feels like a second or third language. And so while the words can be challenging, the information is eminently practical in many cases. So, if you're not comfortable reading that, make sure that you're associating with people that are, because there's so much to learn. And I think there's so much more for us to be able to deliver in these worlds. I would definitely recommend for vocal coaches and movement coaches of any kind to go back maybe and listen to what we were discussing with regards to emotion, and the impact of anxiety states, traumatic events on tongue posture and tongue function. Because, speech as an evolutionary turning point, obviously kind of sits at the forefront of a lot of what our brain was designed to do. Moving is one, so locomotion, and speech is really what turned us into, as a species, what we are. So you can automatically assume that everything vocally related is going to have pretty profound influences from everything that person's ever done. And so I think it is a really remarkable tool in this remarkable space to be able to work with people. In our world, obviously, I'm not a vocal coach. I wouldn't even try to play one on TV. However, what I have found really interesting is that just through trial and error, and what we began to see many, many years ago, is we would do vocal quality assessments. Mm-hmm. And you can see truly dramatic changes in many people from something as simple as a vision drill. Or we do something for your inner ear, and all of a sudden the timbre or quality of the tone of them just speaking. Or if I was working with a vocalist, it's really, really interesting how quickly things can change. But you will become much more cognizant of that when you're looking for it, right? Mm-hmm. So if you are going to include other things like neurologically based work with people, you're going to do sensory stem, you're going to have them do other movement, you're going to have them do eye work, you're going to have them do anything, use vocal qualities as a pre and post assessment, right? How do you sound now? Let's do this. Oh, look, and was that easier for you to generate? I think that's a big missing piece, and it's one of the things that I love as well, because if you're working with an athlete of any kind, if I have you do a motion and then I give you an intervention and then I have you repeat the motion and it's better, it's great because their brain goes, oh, show and tell. I did that. That got better. If you want your vocal athletes to do the work, it needs to be a show and tell process. Mm-hmm. You did this, things got better. That's a very, very nice intrinsic motivator for people. So I think I would just say, consider how you do your work with people and see if there's a way to begin incorporating more show and tell procedures to make sure that you're helping them find that intrinsic motivation to keep doing the work they need to do. Because really, I love science, I love theory, but practice eventually is what changes us.
Yeah. I am all about that with working with the voice of your assessment and then your reassessment, and even with working with those who have a diagnosis of something like spasmodic dysphonia, where if we can get them into a position, which I have a program that I was piloting, and we were able to get some folks into different positions, and all of a sudden their voice was very free. And even if it's just for that moment, them being able to hear that sends a message to the brain that something's possible. And
I love that.
What I believe in, and that's what my work is all about, of trying to help people find their voice, get it back, or just keep it healthy. So I love that. I do want to just mention really quick to all of the listeners, Dr. Cobb just mentioned how very vast and dense research is, although Dr. Cobb's amazing at bringing the language to all of us in the general population, and the blogs that you post and the various programs that you offer. And you do have a free course that you offer too, and all of your YouTube channels. It's definitely a phenomenal way to kind of start really diving into neurology. It's really accessible. The language is, I think, some of the best in how we can start understanding it, as opposed to sitting down with something, reading a research paper and feeling like we have a textbook in front of us. So taking the text information and bringing it to real life application. And you're so great at that. So please, please, please check it out. What are the best ways that they can check out your information and learn more about you and Z Health?
Sure. So our website, zhealtheducation.com. Our YouTube channel is called Z Health Performance. It's pretty decent. It's I've been doing it. We actually started it just for our clients, and it's kind of grown. We have about 110,000 subscribers or something, and there are about 600 blogs on there. I do one a week, and that's one a week for many years now. So there's a lot of information on there that might be helpful. We have an Instagram channel as well. I am not on any of them because I don't like social media, but they are really good channels. For you. we create the content, but I just I have other things to do. So those are the easiest ways to find us. We do have a weekly newsletter as well. And like I said, we have, or as you mentioned, we have a mini course that we understand that movement professionals, we all come from that background, right? That educational background. So whenever you start hearing someone talk about, okay, we're going to work on their hamstrings, but we're going to do that starting with their eyes, it sounds weird. We get it. So we have tried for years to find out ways to go, okay, if you want to explore this information, we don't want it to be a threat to you. So we have a mini course that you can sign up. There's no obligation. I think right now it's about 6 hours of online material. There's a book that comes with it because, we want, if people are going to go through our certifications, our programs, we want them to know what they're getting themselves into. So that's available through the website. And I think you have a link maybe, or we send a link so we can provide that as well. I don't do any of the business stuff. I'm terrible at it. I really, they just kind of we're going to lock him in a room and just leave him there, let him think.
Let him think, record a video.
I at least know our website name, so that was good.
Yeah.
So yeah, we're really open. I have an amazing team that loves neurology, and more importantly, I love connecting with people who want to offer hope to others, right? Whether that hope is rehab or that hope is I just want to get this part or I want to win this championship. It doesn't really matter for me, right? I've told people for years, it's just as much work to get up out of a wheelchair after a stroke. You have to do just as much work to do that as this person will to win a gold medal. The problem is no one's going to give you a gold medal for it, right? So everyone is an athlete. Everyone has to do work. And so we just have to, I love, like I said, connecting with people who are trying to figure out ways to make the return on investment of time of the work as high as possible. So that's really what we do. And so yeah, I'm very happy to talk with you guys. And if anyone listening needs help with, information, stuff that we can provide, just let us know.
Amazing. Thank you so much for taking the time and having this conversation. I had such a blast. And I hope I learned a lot, and I'm sure that the listeners did too. Thank you so much.
My pleasure. Thank you.
Thank you all for listening. If you enjoyed this podcast, tell your colleagues, students, and friends. Subscribe, rate, and please write a review. You can find us on Instagram or Facebook, and feel free to check out my website at www.thevisceralvoice.com for information on programs and upcoming events. I hope you join us next time for another wonderful conversation on The Visceral Voice.